Hello and welcome to Next Phase, where we examine the intersection of health and technology and talk about the future of our health system. I'm delighted to be speaking today with Dr. Michael Bonning. Hi, Michael.
Hi, Simon.
Michael, you're a pretty extraordinary character. We do a quick bio summary. I'm not sure that I can do it justice, but from what I can see, know and understand, you're a Queensland boy. That's where you did some of your medical studenting. Looks like you're quite active in some of the political bodies, AMSA and even the AMA at that stage. And you are a legitimately practicing general practitioner today. You've got qualifications in paediatrics, but you've also had stints with the Navy. You were 13 years there. You've worked overseas in a medical device company. You're a faculty member of Macquarie University. You're a non-executive director at GP Synergy. You're the chair of New South Wales AMA. How do you do it all? And help me rationalise that.
That sounds a lot busier than what it actually is. I mean, lots of those things are all very they're very part-time. My clinical responsibilities day to day are, as medical director of the practice I work in, and then also running the Inner West GP respiratory clinic, part of the Commonwealth Government commitment to helping to manage the COVID pandemic. But beyond that, the other ones really do sink in with what I am interested in, what I enjoy. So a lot of the work with the AMA is about how different parts of the health system work together. In my role with GP Synergy, it's very much around education and training. Same with the university. Those things come together, and then alongside that, you add in a little bit of research. So that's what I enjoyed with the medical device company. That's what I've enjoyed in terms of things through my time with the AMA and GP Synergy, is about how do we understand and generate evidence from some of these changes we've made. Because probably the best way to describe me is, I enjoy the policy and the health systems approaches to solving problems. There's thousands and thousands of great GPs and great non-GP specialists out in, across Australia, but what we need is to harness them into, using good policies that support clinical practice, that are clinically led, that actually make being a clinician in Australia easy, makes it work, but also that makes it the best possible job we can do for our patients, so that things aren't getting in the way. So that's kind of how all of those things, not so neatly, but neatly enough, tied together into a week's worth of work.
I can follow the thread of all of those. What's an outlier is your Chief Medical Officer role with Inspired Adventures. Is that a passion project?
It is. I remember getting involved with Inspired Adventures was a bit, was very much came out of nowhere. My skills from the military include skills around understanding healthcare in extreme environments, about management with very little equipment available to you, and having to make decisions around how you get people in and out of different places. So lots of the aeromedical space. And someone said, that'd be great. We know this organisation, they're always looking for doctors. And then it's been this slow progression of being a Trek doctor and Trek leader, and then moving into the space of being their head of, expedition medicine, and then moving into the space of being a chief medical officer for them, which each one has taken me in, really interesting different things, but it's fun. I get to climb mountains. I get to look after people who are raising money for charity and support kind of that component. And as much as I've done mountaineering with friends and colleagues and on trips before, there's nothing like seeing people who have raised money for something they really care about then achieve something that they thought they might never do. And for some people, that's Mount Sonder on the Larapinta Trail, which is not very high, but it's a real struggle because you do it from 2 a.m. For some people, that's Everest Base Camp, and for some people, that's Aconcagua or even bigger. So it's a lot of it's a lot of fun, and it certainly has created a great kind of network of friends over the years.
That's extraordinary. But back to the topic at hand, you are experiencing this pandemic crisis at both ends of the continuum. You're a practicing doc, but you're also working in one of the respiratory clinics as well. So you're right on the front lines of that, all the way through to some of your roles in the policy agenda. I'm really interested in your view from the bridge, because what we're trying to do here at Next Phase is just bring some clarity to what the new normal might look like and what will happen, especially September and onwards, as we start to move into the new status quo. What are some of your observations today, and how do you think that will last within enduring change into the future?
It's been a huge shift in primary care to move to, probably for many practices, 90 to 100% telehealth consultations. We note from the MBS data that most of those telehealth consultations are still phone consultations, so they're old tech, not new tech. And that's something that I think will cause the department and the minister to make further changes. So that's the first one. I'm sure that over time we'll want to incentivize higher fidelity systems, and so that means that there'll be some kind of differential rebate. The video will be more advantageous for the management of lots of conditions. Therefore, it should in itself have be closer to what we would normally expect in terms of rebate. Phone.
And what's your reflection on why it's phone-based rather than video? Because the rest of business has seemed to have pivoted almost seamlessly to video calling. Why is it more complex in healthcare?
Look, I think two things. The first one, at least we shouldn't say just in healthcare. We should say, I'll speak in primary care initially, which is whole lots of small businesses with clinicians, especially who are quite used to certain styles of practice, and also used to very specific types of remuneration. The rebate system, it does drive behaviour. You create a new rebate, behaviour changes. The government's seen that with the millions of telehealth consultations that have happened. Phones are ubiquitous and they're easy. We've used them all for a long time. And I genuinely think there was a little bit of concern around platform, like what are we going to use? How are we going to do it? Do we have the technical capabilities to do it? All of which I think most practices have gotten over. But then the second part is around the patient. Now, I think if you're in a corporation and you're having to do meetings from home during the pandemic and during the social distancing restrictions, that makes sense because you're being paid to be at work. Therefore, part of the trade-off there is probably that you need to let people into your life a little bit, your home life, whether it's as I am sitting in a study or across the kitchen table or wherever it happens to be. But for patients, many of them have a real split. They want to see their doctor in their doctor environment. They don't really want the doctor to see them in their home environment. I think that's still a little bit of a shift that we're having to manage. I also think that because it wasn't a mandated platform, so we're using Microsoft Teams today, or other people would use other platforms, but because the patient wasn't mandated that they had to use a certain platform, there's been a little bit of what are we going to use, what's safe. There's been a lot of incremental things that for each small group of patients might detract from the experience until a practice got the technology, the approach, and became more comfortable with it, and then educated their patients about it. We've been fairly lucky as a practice to have good leadership through that. The guys who who kind of head the practice have been very thoughtful about this, about how we transition to telehealth, but also how we're starting to transition back to managing some things back in the clinic. And that's been beneficial for our GPs, because as much as dipping the toe in the water of telehealth for the last 8 weeks has been great, there is still things that are missed by not seeing the patient face to face. And while this has been forced upon us in this time, what we have to get better at is working out how to use video conferencing to its fullest capacity. There's some wonderful technological developments from certain platforms where you can assess range of movement by video capture, so they can see. We can do musculoskeletal medicine really effectively from a distance. Almost certainly there'll be a way which we can start throwing more teledermatology. Dermatology has always been a specialty that's been further advanced in the technology space, simply because it's often a visual specialty, which lends itself towards phones and cameras and whatnot. But there's lots of other things where this interaction we're having now, Simon, is still a little bit artificial and forced, as opposed to if you and I were sitting, on separate chairs in a consulting room. It's just easier. We can still see more of the micro gesturing. We can see what's out of frame, because that tells us about the patient's foot tapping on the floor, the kind of the wringing of hands, the things that change our perception of the words. All of those things we are yet to understand how to better bring them into telehealth. So some patient factors, some doctor factors, some technical factors, but we're getting there. And I suspect what will happen, we get to September and we will have really brought most of the clinical community along in that time. Lots of telehealth, lots of practice, really getting it down to a fine art. And then there's uncertainty about what will continue in terms of rebate. As a practitioner, I think that there's at least 25% of the consultations I would do pre-COVID that in a lot of ways would be better done over video or phone. Convenience for the patient, convenience for me, the clinician, ability to structure things around more complicated complicated social or work scenarios. We fit patients in much better when there's absolutely no commute time involved in going to see the doctor, and that's beneficial. The things that have dropped away from clinical practice over the last 10 or 15 years, maybe it was changing before that, but there are fewer home visits conducted in those preceding years. And I think this is a technology to support returning to the patient's home, seeing the patient where they are rather than forcing them to come to where we are, because for some patients that's not achievable. And we know this, that understanding a patient's environment can be really, really beneficial. So this is a form of that. I think it's a form that would open up the consulting item for doing home visits a lot, to do more of this. Now, the other, the long-term thing is, I think I have had lots of conversations in the last 6 weeks, but also some really deep ones with key players in this field around what will continue. And I think there's a groundswell of support for including telehealth item numbers in the MBS beyond September. And that is absolutely to create more flexible practice that is much more patient-centered. It doesn't mean that will go away from the standard in-person visit. I think technology is a long way away from achieving the level of fidelity we need to do that, but there's incredible opportunities there. And even then, I know of good practices within the Sydney region who were already using telehealth, and we're one of them that was using some telehealth beforehand, so some video, and this is just accelerated adoption. And so when we fall back towards more normal scenarios of clinical practice, so what we experienced before, I would still like to think that 20 to 25% of visits can be virtual, can be telehealth, can be video led, so that we can continue to make improvements to the way practice works.
Fantastic. 15 minutes has gone really fast. Are there, just quickly, as we round it up, some other changes you see either in the model of care, the style of practice, the policy needed past this immediate pandemic period?
So so I think some things to do with how practice nurses are used and their ability to contribute to, and also probably on behalf of a practice bill for certain services that are telehealth led. Probably more integration between wearable technology and our patient management systems, where patients can opt in to using the technology that they do every day, which they share with many other apps and devices. My health data seems to get shared with a number of things within my phone. The fact that I can't share it with my GP is almost frustrating. And then the opportunity probably to take this as a learning experience for GPs and also for GP trainees, which is one of the areas I work in, and turn it into a short but well-defined curriculum of upskilling. So at the moment, we think of consultation skills as being the in-person, face-to-face, and those remain, but you layer on top of that further skills for working in the virtual space, and those should be things that we explicitly teach both current practitioners and also trainees who are coming up through the system, because we need to prepare them for the system we want, rather than continuing to teach like we always have, which will just ingrain behaviours that we've always had and therefore not bring us forward.
That's extraordinary. Thank you so much, Michael. We've appreciated having you on the show. Thank you for sharing your thoughts, and best of luck with your clinical practice through this difficult time. Look forward to catching up with you in person again soon.
Thanks very much, Simon.
Thanks, Michael.
Great to see you.